Hello, coffee clatchers. How is everyone? We've got buddy systems going on, people from far and wide. And today we are actually doing something really special. And I credit Mark, my husband, to making this happen. And I just want to say, Mark, you do so much for the world of myofunctional therapy. And it's just amazing. And so I just want to pass it over to you, Mark, because you organized this event with our very special guest. And it's awesome. You're upstairs, I'm downstairs, so we can have elbow room. You know, that's really important in a marriage. So, Mark, go ahead. Thank you for being here. And thanks for everyone for being here.
Good morning, everyone. As I hope you all know by now, we're in our little institute, the AOMT. We're a bunch of crazy dreamers, and we think that myofunctional therapy should be a first-tier line of medicine. You know, for instance, if somebody were to be considered to be potentially suffering from sleep disorder breathing, or it's found out that they have sleep apnea or snoring, or, you know, any kind of, you know, sleep disorder, or any other number of issues that could be somehow related to a myofunctional disorder, that myofunctional therapy should be tried first. It should be applied first. And this is something that for us is maybe a no-brainer, but there is a tremendous amount of work that we must do collectively, some of us individually, to engineer little stepping stones, foundations, to get consensus with scientific societies, to have academies to adopt standards, to have higher and higher levels of research, and to have larger groups, and to have professionalism in training. So we're crazy about organizing training and getting the best training available, constantly pushing it out. So in our journey, for instance, we had to cancel maybe 15 courses around the world last year in Scandinavia, in Hong Kong, Tokyo, France, New York, Los Angeles, and move things online. You know, a lot of the work we do, we look to seed things. And I had the great fortune to meet an ENT who you're about to meet, Dr. Carlos O'Connor Reina. I think we met at World Sleep. I don't know if it was in Korea, maybe 6 years ago, or in Spain 8 years ago, in Valencia. At some point, he'd kind of, you know, come by and we struck up a conversation. He stayed intrigued, and we had a course in Estonia 4 years ago, and he came with his wife, who's a dentist, and he is a sleep specialist, ENT surgeon. He's at University of Sevilla and a very well-known hospital in Malaga, Quirón Salud, and he's like, I want to study. So they came and studied, and he started to get excited, and he's like, I have a vision for this. This is a real thing. It really opened my eyes. And he's like, I have a plan. We must go and get consensus. And Carlos has some information to share. And his paper that just came out this month, on the role of myofunctional therapy in treatment of sleep disorder breathing, a state-of-the-art review. I hope everyone reads this paper soon. He and I were talking this week about a conference I've been asked to organize. So I'll take a step back. The World Sleep Congress coming up. There's a 30 or so year old scientific society called the World Sleep Society. It's the world body for sleep medicine. And it has a meeting every 2 years. The next meeting will be in March of 2022. We organized a joint meeting at the last Congress in Vancouver, Canada. I think some of you were there in 2019. And then 2 years before that in 2017 in Prague. And it was considered to be a great success. I was asked to invite it, organize it again. And Carlos is going to participate in that and in March of next year. And we are going to, have a great 2-day meeting that's a part of the World Sleep Congress. So I'm talking with Carlos. He's like, oh, by the way, I have this new paper. And he shared with me the paper and I'm like, whoa, this is amazing. Gosh, can we get this guy to come off the beach in, on the Mediterranean and twist his arm and come in and join the Mayo Coffee Klatsch? And he's such a good sport. He jumped right in. And I think he may even have a couple of slides. But this is really hot off the press, groundbreaking stuff. And we're really excited to share it. I'm excited to be speaking to the Mayo Coffee Klatsch also for the first time. Samantha's done a tremendous job in making this such a stellar resource. People are so excited, and we're so excited how it's going to continue to blossom and grow. So Carlos is very passionate. He's looking for solutions to help people. He also has developed an app you'll see in one of the or two of the papers that we shared to help support myofunctional therapy training. And he goes to the greatest meetings. There's another thing I want to share is he was just recently informed. He was invited to present on myofunctional therapy and sleep disorder breathing at the AHO and HNS, the American Academy of Otolaryngology, Head and Neck Surgery. It's the premier academy for ENTs in the United States. Some of them might say the world, but they might be American. But that will be in October, and he's presenting in myofunctional therapy for the first time. So it's a historic precedent, stepping stones. This is great news to share. So welcome, Carlos, and thank you for your work and your intellectual curiosity and your passion.
Thank you, Mark. It's a real pleasure to be with you, with you. So honestly, you know that we started our way together in 2017 when we met in Tallinn. We met before in Valencia in 2015, and well, it was a long way. And honestly, I think that we have to share our knowledge together, and we have to try to do the best for our patients. There are no exclusion at all. So this is the way. This is the reason of my work of every day. Well, this is honestly a way that we have done together. And as I told to you, first of all, my disclosure, as I told Mark, we have the creator of this app of Fireway Gym, and we will talk about this later. And well, always that when I speak about this matter everywhere, I give talks everywhere. I always introduce my team. You can never be alone in this way. You have to always talk about the people that work with you, and always work with a pulmonologist, always work with an orthodontician, with Dr. Cuevas, Dr. Ignacio. My another team that is Dr. Casado, my colleagues, Dr. Benjumea, and I have also Doctora Laura Rodriguez, and our last worker that it was Francisca Borman. She was a phonologist from Argentina. She was working with us 3 months. We hope that in the future she will come back to work with us. So, but when we are talking about sleep disorder breathing, you never can speak by yourself. This is a real mistake that when I am honestly listen to my partners that I speaking about, I am a surgeon and I operate hundreds of patients. You know that you always must not do this work alone. You must always work with a team, and this is the way that you can improve and you can learn more things about this matter. And this is the way that we can improve. Well, this is the situation about my functional therapy and sleep disorder breathing. Is honestly is very, very, very pure. If you do Google Trends, you will see that my functional therapy is at least very not poor recognized as a treatment for sleep disorder breathing. And we wonder why, but we wonder why we try to this is something, one of the questions that I make myself. If it's a cheap treatment, if it's a treatment that has no secondary effects, if it's a treatment that honestly is treating the reason of the problem when you are having a sleep disorder breathing, I don't understand why this situation we find when we are looking for a treatment. we know everyone. We know that it's a cheap treatment, that the industry has no interest in providing a solution about this matter. And the problem is that for the beginning, there was a failure in the concept to use this therapy for this disease. And I think that this is one of the ways that we try, of the main issue that we try to solve with our work. This is what our experience. Well, we started in Spain, and we were the first that used exercises to treat sleep disorder breathing. It was 2016. I went to Brazil. I have the experience to visit Sao Paulo. I went to the laboratory of Sao Paulo there. I meet phonoaudiologists there. I meet also a surgeon. I was visiting a surgeon because I am a surgeon. I visit Michel Cajali. But I tried to learn what's the way that the classical myofunctional therapy was applied. And the situation is that I carry with me, I get a very good speech therapist. I get exercises, I get tablet. And well, we are a private hospital. And in all the places appear that we were the first hospital that used this therapy for this. We know that we need more. I know Mark, I know the work, I know the work of the OMT, and I will say that every knowledge adds in your practice. So we went to meet him. I was in Tallinn in 2017. I introduced a lot of concepts for them. Honestly, I was interested in what they were looking for, that was a sleep disorder breathing. But all the things that I learned from Samantha, from Mark, from all the team there was very nice. And I always recommend, and I will recommend this because I told to you, I repeat, everything adds for your practice. But well, this is for the beginning. But now I am really proud to see. I was talking with Mark that our work in our Spain, in our country, has in the end has resolved. This is the last consensus about the treatment of at least sleep disorder breathing in our country. You can see here, this is in the Spanish way. This is a consensus written by the pulmonologists. We are just invited. ENT are invited, but we were very lucky. But one of my team, that was Guillermo Plaza, this one of the co-authors of this manuscript, just started to get that the myofunctional therapy as a treatment for these problems for the sleep disorder breathing. It was at the same way that the surgery, at the same way that as the CPAP, and the same way at the MAT, at the advanced device. This is a real big victory for us. When you read the manuscript, you see that there are no phonoaudiologists, there are no speech therapists invited. But this score right here, this box was because one of our collaborators in all my manuscript was there and has the knowledge and is sure that this is working for the sleep disorder breathing. And this is very important because when we are trying to do any investigation in our country about using myofunctional therapy, we can use this consensus and we can use myofunctional therapy with no problems with any ethical committee, because this is a therapy that can be at the same level as the other. So honestly, it's a very good good news for you in your investigation, and you can show this detail for all your patients that we are talking about something serious.
Well, Carlos, if you could just go back to this slide. I just want to emphasize in this and just make sure that everyone knows, because everyone's like, oh my gosh, what are the words here? So this is a consensus statement from the Spanish Sleep Society. And so what effectively this is doing, this is elevating myofunctional therapy to the level of CPAP, of oral appliances, of surgery, sleep surgery. So myofunctional therapy, this is a historic precedent. And I think this is actually even stronger. So this is brand new. This is a historic moment. And I just want to say congratulations to Carlos and your team, the Spanish Sleep Society and research in sleep medicine in Spain is very well respected all over the world as being of the highest level. And I think this is a profound occasion for us. So, you know, not everyone's muted, but if you were able to listen, you would hear people clapping and applauding all over the world. And this is very exciting.
Mark, can you just translate the boxes so everyone's
Sure.
clear?
So, if you're,
They says that, well, the different treatments, they are complementary, not exclusion. So you have no exclusion for any treatment. So you have, this is the way, when you have a suspect of a sleep disorder, of a sleep apnea, you do the examination, you do a medical examination. You started with a conservative treatment, with a hygienical treatment, low weight, and then you can start with the treatment for this, and you have all these options. And honestly, we recommend to start with my functional therapy, and then you can go for surgery, but the 4 treatments are on the same level. When you read the manuscript, you notice that there are no speech therapies inside. But honestly, this is something that will help to us to start it and to introduce myofunctional therapy in all the sleep units that we are looking for, and we are fighting for to do that in our country.
I will get a copy of the manuscript and share it with everyone, and we'll find a way, to give people access to this knowledge. So this is a profound stepping stone. And I just want to, sorry to interrupt your slides, Carlos, but I wanted to just celebrate that,
Yeah, that's great.
because this is, I think, even, there's a couple different societies around the world which are starting to list myofunctional therapy. But like I was talking with Carlos, this morning, there's like, section 13, subgroup letter C, myofunctional therapy can be considered. This is elevating it to a first-line treatment. And so that if someone working in medicine wants to start with myofunctional therapy, their justification is this flow chart. This is a great precedent. And thank you for your leadership and work.
Well, this is, I told you, I was not the co-author, it was Guillermo Plaza, but he's like my brother. So we were really celebrating this victory, and it was his merit, because it was a real battle to introduce this kind of treatment in this score. But he's absolutely confident about this therapy. He's using in his hospital. He's a head of a very important hospital in Spain, in Madrid, and he agreed, and he's signing with me all my manuscript, and he's going to be professor thanks to the journals, to the article that we have writing, and he's honestly he believes blindly in this therapy. So this is the reason that he tried to fight, and in the end he won the battle. Well,
I want to mention also, and this is important for everyone to know, Carlos has earned this respect step by step, fighting and being very focused, being very careful scientifically. We've had many conversations about taking time, going step by step. So he's gone to meetings, regional meetings, international meetings, national meetings in Spain, and introduced in a very disciplined fashion what they know scientifically, what his experience is about myofunctional therapy. And he's been very careful to work in a strategy to build consensus. And this is part of his vision, is working methodically and carefully, doing research in one aspect and another, in order to get to a point like this, to make a broader foundation and go forward. Would you say that's correct, Carlos? Am I giving it?
That's correct. That.
Could you talk a little bit about that strategy? Why you want to be careful like that?
I told you that you must be always very, very slow to reach long away. This is the far away. This is the trick, and always in science, you cannot go faster, because if you go faster, and then you will end very, very short. You have a long short. So a long short way. So the idea always is in this way is that you have to work with the more people and the more interested people, that they are very, very interested in doing the same work as you, and always people that you can confidence, and they have scientists confidence in all over the world. People that signs with my manuscript, I can assure that to you that they are the first line scientists in sleep disorder breathing, in sleep apnea, in anywhere, and they are very respectful. This manuscript has been signed. My last manuscript has been signed with the president of the Spanish Sleep Disorder Breathing Otolaryngology Society, and we are also one of the chairman of this society. So it's something that you have to go very slow, because honestly we have very difficult issues to fight. So the important way is to go slow and to try not to take care to be fast. This is my impression. And at the moment we have people that came everywhere to visit us, and we are very proud of that. And we have many people that they cure. They show us videos. They are from all the world. They are cured with our plan of myofunctional therapy, and we are very proud that says that I am a surgeon, and many people has avoided surgery or has done the surgery with better result than we use myofunctional therapy than when it's not used. So that is our idea.
That's fantastic. And, you know, a lot of us who are on this meeting, you know, we go to some local meetings or some societies where we find ourselves kind of, you know, that expression, preaching to the choir, you know, where we're talking amongst groups of people who are already converted, who already know myofunctional therapy. And this is, you know, sometimes it's comforting and fun, but people at meetings like this often get ahead of themselves, and we need to proceed in a careful fashion and make sure we collectively come together and organize to make sure that we're speaking in the right scientific language and doing the right work. So thank you for your leadership.
And well, you asked me that this is well, I as INT, I always speak about to all my colleagues the hyperventilation syndrome that I learned with Patrick. I do in the course with Bucheiko. It's one of the courses that I always recommend, and is ear, nose, and throat specialist. I think that is very useful. That when you are operating one patient, just think about the function of the nose, and we know this kind of syndrome. And this is something that will help us to do. We were very proud to collaborate with Patrick and to do his first manuscript, his first scientist manuscript. I am very proud to say that I am co-author. You cannot imagine how many critiques I have received to collaborate with Patrick. But I am honestly, Patrick has his situation, and I respect his work. And honestly, when he invited me to collaborate in this manuscript, that is the way that you can make some investigation about the way that people breathe when they have a sleep disorder breathing, I say yes, go ahead. And also Guillermo Plaza, that is the other guy that was the responsibility for this last victory in the Spanish Society of Sleep. We decided, go ahead. We are going to support him. We are going to have to you in your first publication, and he was really happy. And we honestly with this manuscript, we are putting in the idea that we can try to investigate the way that our patient that has suffering from sleep apnea, how they breathe, and we can change. If there are several phenotypes about the type of the sleep disorder breathing, we can investigate how they breathe, and we can change the breathing. I always ask to my patient how they breathe. I always try to investigate that way. And if they have problems with breathing, I always refer for my speech therapist in order to control that. That is something that I know that no more of the ENTs do that. So this is also another important manuscript, and I am very proud to say that we report with Patrick that we have to sign, and this is something that we are trying to make a clinical trial, but we have plenty of ideas. We have our group gather every month and say, well, what is the next work that we're going to do together? And honestly, this is something very simple, and this is something that depending about the phenotype that you can see, you can change the way of this breathing, and you can help with the breathing depending about the phenotype of the sleep disorder breathing. And it's a very good idea. It's only a hypothesis, and I am very proud to put this with Patrick, that this is his first manuscript, and I am with him. So something that you speak about, you want to speak about the way that we breathe, and this is the slide about that.
I think if you could just go back to that slide. I think this is so exciting. Patrick has been one of our collaborators and one of our faculty for 10 years. And actually, we have a course going on simultaneously right now with about 60 students in it with Patrick. That's live. It started an hour and a half ago. this is something for us. Breathing re-education is a part of myofunctional therapy, and you cannot separate the two. One helps make the other more effective, either way. But I just want to comment on this with these 4 phenotypes of sleep apnea. This is a critical thing. We'll have some other discussions on this, but this is a very important emerging trend in sleep medicine. Looking at the phenotyping, at precision medicine, specifically, what do people do? Because, you know, we all know in the sleep marketplace, you know, Philips or ResMed would like to stick a CPAP on everyone. And, you know, you might have Somnomed or some other company want to stick a mandibular advancement device on everyone. And we all know this is not treating the actual cause or where the breakdown is occurring to create this kind of trauma, this disease state. But to have the specific targeting of the actual phenotypes, where myofunctional therapy or breathing re-education can be applied and how it may work. These are the kind of fundamental questions we need to answer in order to move forward in sleep medicine and help advance myofunctional therapy to become a proper field of medicine, rather than just, you know, something from a black box, or, you know, a 3rd tier response after CPAP has failed, after mandibular advancement device has failed, or after orthodontics has relapsed. There's a quote that I just want to read, Carlos, from your paper on the state of the art in myofunctional therapy. Only by developing clear definitions, objective measurements, and strong scientific evidence will this treatment modality, myofunctional therapy, find a place in the standard treatment of sleep disordered breathing. This is such a great statement, and we need to examine exactly these kind of questions.
Well, our last investigation was based on that. This is something that we always ask ourselves: what was the patient that really deserved this therapy? So this is our last manuscript, and was we need a phonoaudiologist, Francisca Borman from Argentina. She came with us, and she called.
So just so you guys know, phonoaudiologist is a speech pathologist in
pathologist
and she's a myofunctional therapist from Buenos Aires, and she went to do a 3-month residency at Carlos's hospital in Spain, and they produced this paper, which is it's going to be published this week.
We have the idea that it was for us very important to try to identify where was the patient that deserves. And honestly, our practice of people that really cure with sleep apnea, because we have patients that really cure with sleep apnea with our app and with exercises, they cure this disease, and it's recognized by pulmonologists. We decided to try to search what is the phenotype of this patient, and we have a real clear idea. So the idea was to try to identify what are the patients. And honestly, the tools that we have now is a complex questionnaire that they are not available for all the people. And we try to make something simple. The way was to try to compare the OMS questionnaire that is really complex and should be only done by phonoaudiologists, compared with some more easy, that it was the IOP and the tone digital spoon. That is the 2 tools that we have used in our practice, and we are used all the doctors that work in our sleep unit, they can do. Laura Rodriguez introduced the tone digital spoon to treat as a measure to make the strength of the tone. And of course, everyone knows the IOP. I learned IOP in the OMT, and I must always be very thankful to learn this tool there. And well, this we use in every patient, and with this information and sample, we can identify that if you improve your IOP score, you improve your sleep apnea levels. You get better. This is one of the results that we achieve with our randomized trial. It's the first randomized trial that has been used with patient that has severe sleep apnea. You cannot imagine how difficult it was to combine ethical committee that we need patients with a sleep apnea, with severe sleep apnea, EH more than 30, and not to receive any therapy. And the patient that start with the therapy, they should receive only my functional therapy. For us, it was really a victory, because in this way, I was supported by the head of my pulmonology department, that he decides to go ahead with the idea. And in the end, this is the first manuscript that is we can demonstrate that my functional therapy is useful to treat sleep apnea in case of severe sleep apnea. You go anywhere in the world, and no place is going to be treated with severe sleep apnea and functional therapy. In my hospital, yes, my hospital, the first goal, the first start to be treated with sleep apnea and severe sleep apnea is the functional therapy. So we are very proud for that. This is something that this is the result for our randomized trial with our app, and you can see the consequence of this. This is the people that do the exercises with our app. They improve, and this is the control group. The people that they have severe sleep apnea, they must be not doing any therapy during 3 months. 3 months. Some people, they change quality of life. They don't get down the weight, but they change the quality of life. But in this slide, you will see that some people improve, some people don't improve, some people get worse. This is the consequence, the next consequences of our randomized trial. We want to investigate is the patient that could improve with my functional therapy. And this is what our investigation will be in future, and we are looking for that. So we are going to try to look for this, and this is the reason of our investigation. You can see here that people with my functional therapy, they got the best results, the same result that you can achieve with surgery, or you can achieve with the hypoglossal pacemaker, and only with an app that costs only $5, and with the effort of the patients. Something that is like crazy, you know. You are fighting with CPAP that costs $1,000. You are fighting against pacemaker, and in this way, you are honestly offering people that this result that you can improve from 44 to 20, and you improve. So it's something that is really, really a good news for all of us, no?
I want to just emphasize a point, that Carlos is making here, and he's grabbing. Sorry, it's a dog. He's grabbing this example of IOP because we need these objective measurements in order to create diagnostic tools to gain consensus across disciplines. And it's so fantastic that you've done this work. He said he discovered it in the AOMT. We're very proud to have reached out and partnered with IOP over the last 8 years or so to establish and incorporate this in our teaching. And we talk about it in all of our classes. And this is the kind of thing that we need, this kind of data, so we can go back to the referring doctors and say, look, this is the assessment. And the more we get comfort around these questions, the more we'll be able to advance. But thank you for this pioneering work.
Well, we try to do the best. No, this is something that helped. But I want to show to you this is the other our AP. This is the tone digital spoon. That is, you can, now that the IOP is really expensive, and we have the idea to use the tone digital spoon, and it was the doctoral thesis of Laura Rodriguez that she decided to use this. And with this, you can just use for the patient to give an idea of the evolution of the myfunctional exercises. And with this manuscript, you have the option to compare the result with the IOP. So it's something that you can also use in your practice, and we use also in our practice, and we recommend to our patients to use the tone digital spoon. You have also this manuscript, and this is a video of one patient that sends to us that he was doing the exercises, and he invited to us and say, "Oh, I am improving. I am really cured." He has an EH of 60, and he recovered to about 25, and he was very well known in all Seville, and all the immunologists were surprised. And he just was doing the tone digital spoon every weekly to assure that his exercises were improving the score of these of these values. It's something is more available than the IOP for all the people, and we use in our practice and we recommend. It's something that is I recommend you also to use in your practice. Laura is something is a nice collaborator. His doctoral thesis was about the diagnosis of the patient with a sleep disorder breathing and how this changed after improving with sleep apnea. It's something that Guillemino doing in his moment, but there is only one manuscript about that. Patients with a sleep apnea disorder, with a sleep disorder, they have problem with apraxia, they have problem with hysteragnosia, and doing exercises with myofunctional therapy, in this case with our app, they improve the score of the value of the score of the recognizes of these shapes. And it was really surprised that we can discover that patients with sleep disorder breathing not only have a sleep apnea, not only have handicap in the AH, they have also problems with the apraxia, they have also problems with the hysteragnosia, with another values that are not evaluated by pulmonologists, they are not evaluated by ENT, but can be evaluated by phonoaudiologists, and it's something that is a new dimension and something that we try to improve with the therapy. Of course, we try to evaluate before doing any surgery or any other treatment.
So everyone received this paper, just so everyone knows. It's in the bundle of papers that we were able to share with you. And, you know, he had an image up there. As you can see, the tongue digital spoon was like 17 euros, and, you know, which is like $20. So I know IOP is great, you know, but it's also pretty expensive, and you can't send every patient home with an IOP, but you can send them home with a digital spoon. It's ingenious, very entrepreneurial, and great thinking.
No, it's something that honestly, when the question is that when one patient says to you, how I know that I am doing properly the exercises, of course, we can have a monthly consultation and we can make an IOP measure to see if his IOP score has improved. And of course, we try to see how are the exercises performing in front of us. But the way that he can do at home is doing with the tongue digital spoon. We give some videos how to use it. And honestly, it's very useful, and people really improve the adherence to the treatment, and really they are excited about the idea of this. No?
Carlos, and just can you explain how it works? It senses pressure, or how
you have a video in the manuscript. We use a dot here. There is here a button. We change this part of the spoon. And then you press the tongue outside with the dot. And when you are doing the pressure, you have here a score. And just simultaneously, when you do the maximum pressure with the tongue, you hold this button and you have here a score. The score is weight on square centimeters. So you have a measure of pressure. And we teach the patient at a consultation before doing this, and also we give videos. In the manuscript, you have the videos that do Laura Rodriguez and do very well, and you can show how it's working. Honestly, it's something that is very useful for the patient that really is involved in my functional therapy and wants really to go ahead and ask to you properly if he's doing the exercises or not.
By the way, this morning I heard from Laura Rodriguez, who did that paper as her PhD thesis, and also the speech pathologist from Buenos Aires, Paz Borman, and maybe we'll have them come on in a future Coffee Klatsch and talk a little bit more detail about their work.
Well, about this is the consequences I told to you, where we begin from the beginning. We go back and we start with my functional therapy in our unit. We try to do seriously as was done in Brazil. We get books, we get videos, we get a functional therapist, and we told her. But in the end, we found that in our country, we found, I don't know if it's in yours, we found that the people has very low adherence. When I told to this condition, to this problem with another colleagues, they told to me that honestly, the problem is the adherence for this therapy. The reason of this that makes to us sense, this is, well, we have a very good treatment. We have a very good therapy. I think it's the best because it's treating the reason of the problem of the, one of the reason of the main reason of the sleep apnea is the problem of the upper airway muscles. But how we can improve, how we can do better. So we think that about the app, we think that we can, watching the lecture of a very good friend of mine, Peter Batista, he's a very good friend of mine. He was talking about apps in diagnosis of sleep apnea. We say, okay, if we make an app that was focused on the therapy, on this therapy, and the idea was that the patient go ahead, do the exercises against this screen. The screen called the exercises. The exercises was sent to the cloud. The cloud collected the performance of the exercises, and the doctor knows about if he's doing the exercises properly or not. My idea was mainly just to know if the patient do the exercises or not. This was the concept, which was the reason of this app. But for to do this, we try to design a special plugin that can get the pressure, can contact the pressure to the phone. And well, we decided to create some cards that get involved the trainer with the doctor, with the patient, and to get a chat that the telemedicine will help directly with the performance of the exercises with both. You know that you cannot imagine how many work require this, how many legal questions, how many problems holding them, but everything was won. And well, then we got this app, and this app in Spain, in our country, is one of the most sold now. It's not expensive. We decide only to have five euros only with this, but it's something that really helps in the way for we will try to cure our patient. This is our main one issue. And the concept of this app is the interaction between the phone and the patient. But the idea is that the patient has feedback, appropriate feedback. This is a vibration. The patient has, I imagine that has the memory where are the lights located, and the pressure that you are doing is something that is always the same. And in this case, you see how this is the other exercises. There are 9 exercises. The idea is not to move the phone. The idea is not to move the head. And the idea is that this pressure must be always the same. And you have to have in mind that you have to try, as says always Samantha, it's not question of pressure. It's not question of strength. It's question of precision. That is the main issue to treat a sleep disorder. And you can see how is the way you do very fast, you do very slow. It has no answer. And we discovered that this was what we call proprioceptive training. And this proprioceptive training, that is the first time that has been used to treat sleep disorder breathing, is the best way to try to have problems with sensory motor problems. And I am not going to speak about sensory motor deficits in sleep apnea, but patients that has sleep apnea all have sensory motor deficits, like problem with ischemia with the brain. They have problems with coordination, motor, they have apraxia. And we discovered that this way to try to improve and to cure patients is really useful. And we were surprised that our pulmonologist that started to believe in us, he never has believed in my surgery, but he has believed in my functional therapy. He decides to go, okay, go ahead. We do this randomized trial, and to do a randomized trial, you cannot imagine how many papers, how many things you have to do. And of course, you cannot do by yourself. You need to be fasting. And we were very happy that we have a very excellent results. Patients cure. People get from 44 to 20. This is the same as the pacemaker. So this is the thing that we keep fighting with my functional therapy. This is the thing that in my country, my functional therapy now is very serious. They are now that we have to do with the tools that I told to you with polygraphy. Our patients has controlled with polygraphy every 6 months. They have monthly control with IOP, and our specialists, they are well trained. So the way that people, when a speech therapist try to get for this therapy, I will say you have to get very well formed in very well. Get a lot of knowledge in sleep medicine. It's very important to get accreditation in that. In that way, you will understand what you are doing. It's not it's a very severe disease, and you cannot treat it like I know a tongue thrusting or like something like that. This is something that you must have in mind, and this is the way that I invite to all our sleep speech therapists and phonoaudiologists to go ahead. So invite with this.
That's
And, you know,
such an
everything was better.
that's so exciting to have that work and to have your teams going forward in randomized controlled trials and this kind of work. It's such a fantastic precedent, and you keep talking about teams. One of the things I wanted to ask you is that you're an ENT, you're a sleep surgeon, you know, collectively, we have, maybe hundreds of people who will watch this conversation this morning. And how can they go and reach out to their local ENT at a hospital or a local clinic and share this information? Of course, I'm going to say, study the papers that we shared with you so you can talk about fine points, maybe discuss them. But how can people reach out to ENTs and make inroads?
Well, honestly, first of all, this is something that, of course, reading this manuscript and trying to involve in sleep medicine. You have several ways to get accreditation in sleep medicine. You can do courses. In my country, we have the accreditation of sleep medicine. There are European sleep accreditation. I think if you get interest in sleep medicine, is the way that the ENT will trust on you. The way that the pulmonologists trust on me is when I get accreditation in sleep medicine by the Spanish Society of Sleep and by the European Sleep Society. I think it's a very good way that you can demonstrate it, that you have interest and as you are scientists value to do this, to do this kind of medicine. I told you that I was absolutely forget about surgery, but as a surgeon, he does not trust in my surgery, but he trusts in this way. When I started to, yes, it's a sad, but this is true. The question is that they only trust in CPAP, and this is the way that, every people works in the way, but the idea is to get all together, and it's the way that you can grow. I recommend just to try to get knowledge in sleep medicine and speak with the same language to this specialist. And of course, all people, all ear, nose, and throat specialists has patients that cannot cure. And if you go where you have a very good scientist basis in sleep medicine, you can help to your ENT to try to cure this patient that no more can be cured with surgery. And anyone knows, and of course, if you do surgery about sleep, you always have failures. And this patient that has failure, if you have an option to try to improve his results, he will open the doors. Of course, I am sure about this.
Yeah, so the sleep training, I can't emphasize enough. It's so critical, and this is one area that I've led an effort to make our inroads. Like, we're working with the World Sleep Society or the International Pediatric Sleep Association, but also the technologists. We need to make inroads. We have a course that we consider to be part of our fundamental foundation in myofunctional therapy that we haven't been able to offer since COVID, that's on comorbidities of low tongue posture in the airway. And we're really excited to be getting this online. And I think we should have a conversation with you about adding you to the faculty of this course. So that would be exciting. That would be great. But I know some people may want to ask you some questions. We're kind of approaching the hour. I want to mention too, this precedent of you speaking at the American Academy of Otolaryngology Head and Neck Surgery meeting in October. How can we continue to push that forward, that information? I mean, I'm like, oh my gosh, I think I have to go in person and to that meeting because it's in Los Angeles. And I'm sorry, you're going to be in Spain at the time. We all have COVID flare-ups, but how can we continue to make these kind of inroads with ENTs?
What? Repeat. I was looking.
How can I know you're speaking at the Academy meeting in October in Los Angeles, and this is such a great milestone. Beyond research and continuing to do this heavy lifting, this work like you're doing, how can we make advances in this academy and others around the world?
Well, the idea is that I was surprised that this course was accepted. Honestly, when you send the course to the American Academy, I have one in 2010 in Washington, and again, it was not accepted. And now this was accepted, and I'm very happy that I'm very proud that I'm going to do this course with something very good as sleep surgeon that are Rodolfo Lugo, Peter Batista, and Guillermo Plaza, my friends. And we are going to defend my functional therapy in the place that all people have surgery. So, well, the idea is that just it's starting. They allow to me to speak half an hour, but I am very proud they allow to me to do this. So this is the beginning, and you know, little by little, you are doing the way. This is slow, but it's safe. So this is another place that we can say that my functional therapy is recognized by the ear, nose, and throat, by the American ear, nose, and throat. So it's the way to start. Perhaps the next year will be 1 hour course, and perhaps there will be more than 4 courses. I don't know, but this is the way that in the course we are trying to see what are the limitations of this therapy, but we saw that we can do some pairs, introducing the diop, introducing the tongue digital spoon, introducing some guidelines to recognize my functional disorder in the patient that has a sleep disorder breathing, that I think we think is mandatory. And it's not all operated, it's not surgery. There are more things as important as the surgery, and we want to do in that course. So let's start.
So there is that's a fantastic point. If people have questions, if you want to put them into the chat box, you know, I've seen a lot of questions come up over the course of that hour. But I think we'll be happy to have Carlos back on a future topic, because you're doing so much profound work. But one thing also, you started out this discussion with, I just want to bring back, is you talked about there was a failure to add treatment in sleep medicine. And I wanted to clarify, when you first started speaking, one of your first slides, you said when you're looking at treatment in sleep medicine, there was a failure to add. Were you talking about myofunctional therapy? Was a failure to add that? Was a failure in sleep medicine?
Well, you know that there is problem with myofunctional therapy in sleep medicine, and we have to try to give more scientists report. You see that sleep disorder. I told you that we have 5 manuscripts reported with a sleep disorder breathing and myofunctional therapy. When we are talking about surgery, there are 100. When we are talking about CPAP, there are 1,000. It's right minimum. And when one patient is diagnosed of sleep apnea, what is looking for a therapy, for a treatment, and then he started with CPAP, he started with surgery, and he cannot find really something that combines with my functional therapy. So the effort is try to give good lectures, good manuscript, good investigation, and to try to do it in the same way, on the same languages. Our last manuscript tried to focus on the concept, to focus on the diagnosis, and I think this is the beginning. So, you know, let's go.
Vámonos, let's go. I think that's fantastic. And I mean, it's so much a part of the kind of foundations that we dream of making and we work to do every day. I wanted to also, you know, talk about what do you think is necessary? You know, you're hitting on the same themes: more research, good studies, you know, being careful in how we come across and how we present ourselves, and training in sleep medicine. Are there any other, you know, pieces of advice that you think should be looked to as guidelines for people?
No,
I mean, we know that myofunctional therapy works. That's
no, I think that honestly, when I have a patient that really has been cured for my functional therapy, try to give his testimony to help all people, all other patients that have the same problem, and they understand that we are not looking for economical interest when he has been cured with a $5 ape application, and he honestly give us his lecture, and we use his health, his testimony to help another patient to go ahead with this therapy, or at least to know this. But I know that is complicated. It's difficult to that.
Samantha, did you see any questions that are fielding as we're getting close to the end of the hour?
Well, I know that there was a question around the use of the digital spoon for therapists versus patients, or is it all for patients?
Well,
no, you can do for both. If you don't have the IOP, you can use this in your practice. In our last investigation and our last research, we used both instruments to try to identify patients with hypotonic phenotype. We try to do that. Okay, so.
As we have just like 3 minutes left. I don't know if Laura Rodriguez joined or Francisca Borman. If you guys want to say hello, they sent me messages while you were speaking, and I don't know if they happened to join, but maybe raise your hand on Zoom if you're there to say hello. Otherwise, we will look forward to having you at a future version, a future Coffee Klatsch. And we're very excited about this, Carlos. I can't say enough to compliment you and your team for your dedication and your research. You know, a couple times I've asked Carlos, you know, to come and present lectures or symposia. He had a great contribution at our AMS Congress, September last year and August last year at the 5th Congress. And we look forward to him participating in the AMS meeting with World Sleep Society at the World Sleep Congress in Rome in March.
It was a real pleasure to go there.
Yeah, it's fantastic. And say hello to your wife for us too.
Yes, okay. Mike is right here. He's
have her come say hello.
Dile, saluda. He's now to you.
Hi.
Hi, very nice to see you. Congratulations on your work too, because I know you guys are a team, and thank you for your vision and leadership as well.
Pleasure to meet you. Thank you.
Well, I really do appreciate you coming in, and in the middle of summer, that's a big step for
yes,
a Spaniard on a Saturday in July. So I really appreciate that, and we all do, because it's very inspiring and it helps us have the armamentarian that we need to move forward. We need the data and we need the proof that we all know is in the pudding. So thank you again, Carlos.
Okay,
well, I know he's going to change into a swimsuit and go jump in the Mediterranean after this.
Okay.
All right, everybody, we're going to conclude for today. Thank you for being here. It's wonderful to see you all, and we will be back. So stay tuned. We'll follow up with some emails as always, and
we'll look forward to sharing also the slide with the precedent from the Spanish Society that you guys can have as a reference point.
Absolutely.
Muchísimas gracias, Carlos y equipo.
Okay.
Have everyone a wonderful day.
Okay. Bye, Carlos. Bye, everyone.
I love coffee, I love tea, I love the Java Jive and it loves me. Coffee and tea and the Java and me. A cup, a cup, a cup, a cup, a cup. I love Java.